So we are going to revise 2 lectures from Monday and Wednesday. And let's start with the something easy and might be more interesting, revision on the skeleton. So we talk a lot about skeleton on Wednesday, and sometimes you feel, hey, it's too much, my head is exploding. But yeah, because we are studying human body, we got like 4 or 5 months to study, and after this you will never come back to anatomy unless you really want to do BSc or master in anatomy, and you will move on. And when you go to your new environment, that might be in the medical environment or urgent care or anything. And then I hope these few little lectures will stick in your mind and give you some basic foundation for your further knowledge. So let's start. So this is the diagram we studied on Wednesday. Like, this is half of the human skeleton. And don't forget, the skeleton or whatever we see in front of our eyes, they are in anatomical position. And it is we will be standing on the front of the skeleton or on the side of the skeleton or on the back of the skeleton. We are the person who is rotating around these patients and these bodies and these diagrams. So if the skeleton is not in an anatomical position, it need to be mentioned, and it will be mentioned. So if it is not mentioned, the skeleton is in anatomical position. It is we, you, and me who is standing in the front of the skeleton or at the back of the skeleton. So don't forget that. So everything we see in anatomy they are in anatomical position. So this is the right side. And I hope you remember the humerus and radius and ulna. Radius is on the lateral or outer, farther away from the center of the body. And ulna is on the medial or closer to the center of the body. And big thigh bone, we all know that's femur. And 2 bones in our leg, bigger one, tibia, smaller one, fibula. So that was one of the slides we studied. So I thought it might be more interesting if we have a chance to see slightly more in a apply. So I believe we can all see there is a fracture in this bone. So what is this bone?
Humerus.
Humerus, yeah. So this is the humerus fracture. Yeah. So just instead of looking at that, hey, this is humerus, this might be a little bit more meaningful, more real. That's what we are going to see. So this is a humerus fracture. Which part of the humerus fracture?
Proximal.
Yeah, proximal. Brilliant. So proximal humerus fracture. I believe, we all remember this is the epiphysis region. And this might be the fracture diaphysis or proximal humerus fracture. And let's say, what is this? So we are working together in ER, and you are my junior, I'm your senior, and you want to tell me, hey, I have a patient with this. What is that? Which bone is fractured? We can see a big broken bone here.
The humerus?
Humerus fracture. So the previous one is you are going to tell me, hey, Mo, I have a patient with proximal humerus fracture. So this came in my mind. And the same thing, what are you going to tell me with this? Which part of the bone? Epiphysis, metaphysis, and shaft of the humerus is called diaphysis, isn't it? So diaphyseal fracture of the humerus. So that's what we talk about. Epiphysis, metaphysis. Metaphysis is the flare region, which is also called proximal or distal. And then this is the long bone, the shaft of the long bone, that is called diaphysis. So this is the diaphyseal fracture of the humerus. So now we are trying to combine our knowledge, proximal, distal, medial, lateral, epiphysis, metaphysis, diaphysis, and a bone. Yeah, so this is the proximal humerus fracture, easy. This is the diaphyseal humerus fracture, fracture of the humerus in diaphysis region. And if the fracture is somewhere around here, distal humerus fracture, because we said this is here, fracture here is proximal humerus fracture. So fracture around here will be distal humerus fracture. And this is the diaphysis. Diaphysis means the shaft of the long bone. Okay, let's go to the next page. So we can see the fracture here. Which bone is broken?
The radius and the ulna.
Oh, radius and ulna, perfect answer. Where is the fracture? Which region is it?
I say diaphysis,
Very good. Very
but
good.
I say it differently than you, so I might be saying it wrong.
No, you are right, because it is diaphysis, isn't it? If the fracture is here, you might say proximal radius or proximal ulna. If the fracture is somewhere around here, you might say distal radius or distal ulna, but it is in the shaft of the long bone. That is the diaphyseal radius and ulnar fracture. And if you look at carefully around here, what can you see? Something significant?
The epiphyseal growth plate.
Yeah, epiphyseal growth plate. That means this patient is skeletally immature. So radiologically, this patient is a child. Yeah, a child means, it's not old enough, not like you and me, like the bone are fully fused. This patient, the bone, they are still growing, immature skeleton. I don't know the age, might be 12, 13, 14, doesn't really matter. But we need to appreciate this X-ray we are looking at is the child's age is not he's not mature yet, he or she. Right, perfect. What about this? Similar, very similar. Where is the fracture?
A distal radius.
Yeah, this the radius and ulnar fracture. But this patient is, really old already. If you look at the quality of the bone, this is big hollow bone, very thin bone here. This is a very thick bone here. So this is a child who is growing really, really well. And this is an elderly person who is has osteoporosis and arthritis as well, here and there, arthritis, and fracture of the distal radius because they are osteoporotic. Usually they are weak, they are not steady, they had a fall on the outstretched hand, and then deform, coming to the ER with the deformation in the wrist, and that is what we see. So now, if I go back to this slide, so you have seen the bone here already, and you have identified the site of a fracture on the X-ray. So yeah, so nearly the humerus, radius, ulnar, proximal, diaphyseal, distal, or radius, diaphyseal, or distal radius fracture. You have seen these all these pictures, which is brilliant. What about this?
The femur.
Which bone is it?
The femur.
Yeah, femur. And this child is, oh no, this is a child, isn't it? Because we can still feel the physeal growth plate here and physeal growth plate around the knee as well. Yeah, and the diaphyseal femur fracture. And this is the pelvis, this is symphysis, this is the pubic bone, this is the ilium. The ilium and the pubis here, there is also another growth plate which is not fully fused yet. So this is a femur fracture. Of course, it is in the shaft of the femur, and therefore we will say diaphyseal femur fracture. In a immature skeleton, why do we say immature skeleton? Because we can still see the physis here, physis growth plate here, and physis growth plate here. Right. What can you see then?
A tibia and a fibula.
Tibia and a fibula fracture. Look at that. This is a child or an adult?
Adult.
Adult, because no physeal growth plate, no more growth plate. So this is at least skeletally mature already. We don't know the age, but we know that this person is skeletally mature, and bits and pieces, what we call multi-fragmentary fracture of the tibia and fibula is just fractured. So this is the bone, tibia and fibula. Instead of going back to that previous, very simple, easy diagram, our knowledge has progressed.
Is this a posterior view?
Because
I don't see a kneecap, patella.
Yeah, kneecap is, we cannot see. It's just the, just cut off, because if I go above, I will have they will have what you call the patient's name.
And then
And this is the knee from the front.
Watch if I do this.
Okay, so the front view.
Yeah, if they do this, and because of the twist and turn, like when they try to do the front view, the foot is twisting, or the leg is twisting already, because there is no more connection between the knee and the distal part of the fracture, just twisting around everywhere. Right. Okay. We all remember this diagram. It is about our hand. And as we always say, this is in anatomical position. This is the radius, which is on the radius side or the lateral side, which is farther away from the body. And this is the distal ulna, which is closer to the center of the body. And this will be the thumb, because it is shortest, and it is close to the radius. And this is our little pinky, little finger, which is on the ulnar side. We remember carpal bones, metacarpal. Metacarpal is the bones on our hand, and the phalanges, our finger bones, proximal phalanx, middle phalanx, and proximal phalanx, middle phalanx, and distal phalanx. These are the metacarpals. So thumb, index, middle, ring, and little finger. Yeah. When we talk about the hands metacarpal, we will not, or the fingers, we will not count as first, second, third, fourth, fifth. It is not a correct way to say that. The correct way in our hand is thumb, index, middle, ring, and little finger. So metacarpal and phalanges, distal phalanx, middle phalanx, and proximal phalanx, and metacarpal. And we remember the carpal bones. Carpal bones, we have 8 carpal bones in our body. And they are arranged in 2 rows. So 4 bones in the first row, and another 4 bones in the second row. That is the carpal bone, which are in total 8 bones, arranged in 4 and 4, proximal and distal. And this is the way we try to look at. So radius, ulna, from the radius to the ulna was proximal row. She looks too proud. So she looks too proud. So scaphoid, lunate, trichitrum, and proud, pisiform, which is really small. Therefore, we cannot see in this section. And the second row is try to catch her, trapezium, trapezoid, capitate, and hamate. She looks too proud, try to catch her. That is the anatomy we study from this, and then move into that. And let's say if I show you this, what can you see then?
Is that a scaphoid fracture?
Perfect. Perfect answer. Yes, scaphoid bone here. Fracture in the waist. Lunate, it is there. Trichotillomania here. Trapezium, trapezoid here, somewhere will be here. Trapezium, this is the trapezium, this is the trapezoid. Catch, capitate, and hamate. So this is the scaphoid fracture. The usual history is, a cyclist fell off from a bike, landed on the outstretched hand, came to emergency room. They have pain and tenderness at the base of the thumb, which we call anatomical snap-box. And if we do that, that's a straightforward diagnosis. Sometimes they do X-ray in ER, no fracture seen. These patients who had a young patient outstretched hand with wrist pain, normal X-ray, they need to be followed up again in about 10 to 14 days, because initially the fracture might not show there. And with time, the fracture line will gradually more and more apparent. And therefore, they need to be seen again in like 10 to 14 days time in clinic. This is the scaphoid fracture, and this is the scaphoid bone, lunate bone, trichotillomania, trapezium, trapezoid, capitated, hamate. So these are the 8 carpal bones in our wrist, and these are the metacarpals. Thumb metacarpal, index finger metacarpal, middle finger metacarpal, ring finger metacarpal, and little finger metacarpal. We are not to say first metacarpal, second metacarpal, third metacarpal, fourth metacarpal, fifth metacarpal. Yes, you can say that. That's a little bit loose. So to be precise, we have to name the fingers in hand. Thumb, index, middle, ring, and little finger. But in our toes, we can say first, second, third, fourth, fifth. We can do that in our foot, but not in the hand. Okay, let's move on. So this is the sagittal scan. I believe you know the sagittal view, like looking from the side, sliding the body in many different slices, probably from medial to lateral. And we are looking at the spine. Here, what we can see is, like a yellow arrow showing the fracture. Let's count which vertebral body is it. So what will be the good landmark for counting the number in the cervical spine? Usually the second cervical vertebra. Second vertebra has odontoid peg, odontoid. You remember this big pointing from the second vertebra up like that. So anything tall and long as a column on the lateral view at the top, this is the second cervical vertebra. And this is the first cervical vertebra, which is just a ring like that, just a ring like that. And second cervical vertebra is also a ring as well, but at the top it has got this pointed, and they are connected like that. So if we see that, then we can see the odontoid peg of the second vertebra. So this is number 2, 3, 4, 5, 6, 7. Yeah, this is the 7th cervical vertebra, which vertebral body is fractured. And of course, it is here, it's exploding, it is pressing on the spinal cord as well. So I'm not teaching you about radiology, but we are just trying to imply our anatomical knowledge. And these are the easy bits which we can easily take. Okay, let's move on. So I believe we all know this. Which part of the spine?
Lumbar?
Lumbar. Perfect. Lumbar. So we can see the fracture here, lumbar vertebra. Which vertebral level is it? How do we calculate that? In the lumbar region, we have to find the sacrum, isn't it? This is the sacrum. like the shape of the sacrum and the lumbar vertebra is slightly different. This is more like a square, and this is more like a being squashed already. So this is the sacrum. So this is sacrum 1. So this must be lumbar
5.
5. Yeah, only 5 vertebrae in the lumbar. So 5, 4, 3, 2. Lumbar 2 vertebra fracture. You guys really doing really good. So sacrum, always for the lumbar spine, always go and dig the sacrum. And once you got the sacrum, you will appreciate the lumbar 5 vertebra. So because lumbar has only 5, isn't it? How many vertebrae do we have in thoracic spine? 12, isn't it? How many vertebrae do we have in our cervical spine? 7. So this is the lumbar 2, and you can see, you know, the bones are really thin out. So this is like an old person with osteoporosis. So the bone density is poor, and it is just like a little eggshell. So when we become 85, 90, our bones will be something like that. We all get it. So osteoporotic bone, the bone surface is really thin out. It's just like an eggshell. Even with minor injury, hey, we just crush our bone. But anyway, this is the lumbar CT scan, and this is the sacrum 5, 4, 3, 2, 1. Okay, this is a reminder of how many vertebrae do we have in cervical spine. We will have 7. In thoracic, we will have 12. In lumbar, we will have 5. Sacrum, 5, but they are all fused. And coccyx, we have 4. They are again like they are all fused. So in total, we do have like 33 vertebrae, but some people, they might have only 22. Some people, they might have 34. Doesn't really matter, just average is 33. And this information we take into these diagrams, and they become a little bit easier.
I have a question.
Yep.
If a patient only had 32 vertebrae, which
Yeah.
ones would they likely be missing?
Usually coccyx or
Okay.
sacrum.
Okay.
Yeah. So not the lumbar or thoracic or cervical. Sometimes, like their sacrum is fused with the lumbar 5 vertebra, and it can be very difficult for us to appreciate, you know, lumbar, which is lumbar 5. Is it sacrum or is it lumbar 5? Doesn't really matter, because these are the miniature, because we are looking at the more generalized picture. Okay, so that's the 7, 12, 5, 5, 4. So I believe, you know, it's no longer new information for you. And we talk a lot about, you know, we spent about 2 hours about the vertebra, and these are the different shapes of the vertebra at different level. This is the shape of the cervical vertebra. This is the shape of the thoracic vertebra, and this is the shape of the lumbar vertebra. We are doing like transverse section. We are looking at the vertebra from the top, and you can see the heart shape of the thorax. It is like a heart. You can see more like oval shaped body in the lumbar vertebra, and you can see something like oval, but all these little bones are like small and flimsy. And you can also see the transverse process on each side of the vertebra. So if you put, you know, transverse process multiple on each other, there will be a canal. In this transverse process, we will have our vertebral artery, which is coming from the heart, going along the vertebral body, and then going into the brain to give circulation for the blood supply to the brain. But what I want you to do is I want you to appreciate the different shapes of the vertebra at different level. And it is not difficult to remember, because as we say, you know, bodies are different, we have cervical, we have the transverse foramen on each side, and vertebral column is really wide and gradually smaller and smaller. That is because when the spinal cord, once it is coming out from the brain, it is really big, and gradually at different level, it gives all the nerve fibers, and then when it comes to the lumbar region, it hasn't got much to give anymore. It has given quite a lot. So in this cervical level, it is spinal cord is really big and give branches. Thoracic level, it has given a lot already and not much to give anymore. So just appreciation, you know, it's nothing more detailed. Don't dig in too much, but at least you can pretend you know. Hey, this is the forehead. Forehead is made of frontal bone. We know that. On either side here, we have the parietal bone, which is this red-pink color, and temporal bone just above the ear, around the ear region, temporal bone. And we will have the orbit. So orbit for the eyes, this is the right eye orbit, and this is the left eye orbit. This is the floor of the orbit, orbital margin, maxillary bone. So that is all our upper lips and then around the nose. And cheekbone is called zygomatic bone, and this is mandible. Yeah, so not difficult, but you know, if you look at inside the orbit at the back, we have the fissures. I mean, these are the little cleft opening, which will bring the nerve from the eye into the brain. So these are the little cleft. That is what we call fissures. So here, superior orbital fissure at the top. This is lower. So upper means superior, lower means inferior. Inferior orbital fissure, superior orbital fissure, and optic canal. Optic canal is for our optic nerve. It is the nerve coming from the eye, which will go backwards into the brain to the occipital lobe. So these are the little structures we talk about. And if we knew that, we have studied this as well. This is the right orbit, left orbit, and we can see the nasal sinuses, and just around the maxillary bone is maxillary sinus. Yeah, because this is the maxilla. So we will have maxillary sinus. From around the eyebrow on the frontal bone, we have frontal sinus, and this just at the base of the nose in between two eyes, we have ethmoidal sinus, and there is sphenoid sinus. In clinical importance, what we need to bring is if somebody is having cough and cold and lots of pain around their face at the fronts in the nasal sinus region, you need to think about nasal sinusitis. Yeah, maxillary sinus sinusitis, sinus inflammation of the sinuses. So these are the pain we get with inflammation or infection, or some people will even have pus inside the paranasal sinuses. So this is from the AP or coronal view. This is the lateral or sagittal view. So if we knew that, if we have this information, this knowledge, I think we can apply to this. What can we see then? This is a little bit difficult question. We can see the right eye here. We can see the left eye here. We can see the maxillary sinus here. And this is the nasal concha, nose. This is the oral cavity. This is the right eye. This is the left eye. We can even see the shadow of the eye. And if you look at the inferior border of the eye, it is nice and smooth here. Here, there is a big step in the broken bone. So that is the knowledge coming from this diagram. So these inferior orbital margins are smooth, and you can see little holes here, that is inferior to the orbit. So that's why I will give a name, infraorbital foramen. Foramen means opening. Infraorbital, infra means below, orbital means orbit. Below the orbit opening, infraorbital foramen. So this infraorbital foramen is small, but it's really important, guys. Because we are going to get a nerve coming out from this infraorbital foramen to give the sensation on the maxillary region, on the front surface of your face. So this tiny little structure, infraorbital foramen, infra, below, orbital, orbit, below the orbit, foramen means little aperture or opening on right side and on left side, and a nerve which comes out from the infraorbital foramen. It gives you sensation which is colored with this purple area. So with this, you know, I know we cannot see easily, but that is a fracture of the floor of the orbit, orbital floor fracture. So the usual scenario is, hey, a guy went out, fight in a nightclub, being punched, fight, and then come back home and sleep. The next morning, he finds it difficult to move his eye on the left side, and he cannot feel the sensation on the face, below the eye, on either side, on the left side, or on the left side, or on the where the fracture side is, like cannot feel properly on the face. That is what happened. Because being punched on the face, this floor of the orbit bone broken, and you can see a bulk of muscle of the eye muscle coming out into the maxillary sinus. So the muscle is trapped. That's why he cannot move his eye. And on top of that, infraorbital nerve was damaged. That's why he cannot feel sensation on the face. So that is a really typical picture. I mean, but this, how do we calculate that? Of course, we calculate all these from this picture. Being punched on the face on the left side, here the floor of the orbital foramen broken, the muscle inside the eyeball and trapped, and this little infraorbital foramen, infraorbital nerve damage. That is the usual story we get. Oh, that is a really serious picture. We can see a cranium, 3D, three-dimensional reconstruction. The part of the cranium is being compressed, depressed into the inside. That is what we call depressed skull fracture. What do you think? Which bone is going to get involved with this fracture?
The frontal bone and
Frontal bone and
parietal.
parietal bone. Yeah, that's very good. You know, frontal bone and parietal bone. I'm not sure it will extend into the temporal bone. I'm not sure, but at least it is obvious that the parietal and frontal, they are involved. I mean, the chance of this patient living is pretty slim, but you never know, you know, it's so difficult to judge somebody's luck. Anyway, this is a depressed skull fracture of the frontal and parietal bone. They might be extending into the temporal bone. There must be significant injury into the intracranial structures like the brain, meninges. So this, how do we know which bone is what? Of course, that is the diagram we studied. So frontal bone at the forehead, frontal forehead at the front, parietal bone on either side, parietal bone, and at the back, occiput. Everyone knows occiput here. Only one bone, parietal bone, two bone, right parietal and left parietal. And the same names will apply for the brain lobe inside. So the part of the brain which will be here will be called frontal lobe. the part of the brain which will be here, sitting here, will be called parietal lobe of the brain. The part of the brain which will be here in the occipital region will be called occipital lobe. And the part of the brain which will be here is called the temporal lobe. So it is easy to remember with the bones and the brain lobes inside. And here this little sphenoid bone. Sphenoid bone is, as we say, which is very small on outside, but it contributes a big portion inside the skull. And it gives a little sella tessica, like for the pituitary to sit in. You remember the temporal bone, which is pointing forward as a zygomatic process, and which will come and join with the zygomatic bone. Zygomatic bone is our cheekbone. Zygoma, zygomatic, and this is the maxilla and mandible. And the sutures, of course, it is running in the coronal plane. We'll give it coronal suture. If the suture is running in the sagittal plane, we'll say sagittal suture. And this is the little bit awkward name, lambdoid suture. Lambdoid suture. And parietal and temporal lobe is squamous suture, because this is the squamous portion of the temporal bone. Why do we say squamous? Because it is thin and flat bone around here. And we cannot allow to damage this region because the bone is thin. There is a big important artery underneath. If we fracture the squamous portion of the temporal bone, it will bleed inside. We'll be in trouble. And mastoid process, I believe we all have feel ourselves, which is behind our ear. That is a bony prominence. That is the mastoid process, which we all should be able to feel. Hey, I can see a fracture here. I can see a fracture here. So which bones are fractured? This bone
distal tibia.
Yeah, distal
distal
tibia
fibula.
and distal fibula. Yeah, that is correct. Perfect. So this is the tibia, distal fibula, distal fibula fracture, and distal tibia fracture. So this is the ankle fracture. Yeah, this is the ankle fracture. So once we have gone through this, this slide became like looking funny for you guys. Yeah, because you have studied much more than this little slide. And this became easy. Humerus, radius, ulna, femur, tibia, fibula. And that's what we were talking about. And the bones of the hand, like metacarpal, phalanges, and carpal bone. Carpal bones, a little bit difficult to remember, but try to remember that mnemonic. She looks too proud, try to catch her. Sometimes you will forget try to, what does it mean? Try to, trapezium, trapezoid. So just the way, you will forget when you go and study physiology, but at some point when you come back, when you get a chance, you have some foundation in your mind already, and you can build it from that knowledge. Okay, so that is the lecture slides for the skeletal revision. So I'm going to stop sharing this slide. So let's start from the easy bit and more interesting and more, what shall I say, clinically oriented, more human related. So we said we have two types of muscle fiber, or in other words, we can classify muscle fibers into two ways. The first one is how they make energy, ATP, or how quickly they use energy for contraction and relaxations. In other words, how fast they contract, how fast they break down the ATP. So how do they make ATP and how quickly they can break down the ATP. So two types of mast cell. So let's start from this side. How do they generate their energy? Some mast cell fibers, they will use oxygen for ATP, and these fibers will be called oxidative fibers. And some mast cell fibers, they will use glycogen, glycolysis, and therefore these fibers will be called glycolytic fibers. Yes, there will be a few fibers which will take the good part of the oxygen, which will take the good part of the glycolysis. So some mast cell fibers will be hybrid, you know, like both oxidative and glycolytic fibers. So these oxidative fibers, they use oxygen to generate energy for the mast cell contraction. So, which means because they are using oxygen, they will need a lot of blood supply, because from our blood, the mast cell is going to get oxygen. So there will be a lot of capillaries to supply oxygen to the mast cell. And the mast cell itself has a pigment which is called myoglobin inside the mast cell. Mast cell is called sarcolemma. It's like cytoplasm in the other cell. Mast cell, the name is slightly different, sarcolemma. So inside the sarcolemma, there will be a lot of myoglobins. These are the pigments which will take as much as they can oxygen from the capillaries. And once they got the oxygen from the capillary, they will use it in the mitochondria to generate energy. So these oxidative fibers, they will have lots of capillaries, they will have lots of myoglobins, they will have lots of mitochondria, they are going to use lots of oxygen to generate energy for their mast cell contraction. Because it is a multiple process, you know, this process is slow. So these fibers are usually slow and oxidative fibers. Like the best example for these fibers are the mast cells on our back. Like you saw the mast cells like trapezium or latissimus dorsi, big mast cells in the back. You know, as long as we are standing or sitting, they are contracting. They are not tired at all. Like for the whole day, if you are sitting for the whole day, if you are standing for the whole day, they are walking and they are not tired. They might get tired, you know, at the end of the day, but they can do their job for the whole day because the oxygen supply for the body is constant. Because as long as we are breathing and our heart is beating, we will get oxygen, and that oxygen will be delivered to the whole body. So that is the example of slow oxidative fibers, which use a lot of oxygen. The mast cells have a lot of capillaries, a lot of myoglobin, then lots of mitochondria to generate energy, but it is a slow process. And therefore, these mast cells cannot contract quick. You cannot contract quick with your back muscle. And because of the myoglobin, these mast cells are more or less red in color. So what about the glycolytic fibers? So glycolytic fibers, they use glycogen, store glycogen, they break down the glycogen, glycolysis, and then they generate energy. It is quick. You don't need oxygen at all. You just, like, you don't need to go and find for many. You just spend whatever you have in your pocket. It's cushy, isn't it? But how long can you do this? You are not going to spend a lot of money because things will gradually run out. Many will gradually, the same thing, like you are using the glycogen in your cell to generate energy. Yes, it is quick, but how long can you do it? You can't do that for a long time. Everything will run out. So these glycolytic fibers, they are quicker to contract, but they run out quick. Therefore, they cannot do it for a long time. So these glycolytic fibers are fast glycolytic fibers. So fast means they can contract like the muscles in our hands, upper limb muscle. Like if we do that, if we flex and extend, we can do as much as we like, quick. But how long can we do it? We cannot do that for the whole day because the glycogen supply inside will get depleted and you will get exhausted. So these muscle fibers, fast glycolytic fibers, they use glycogen via the glycolysis and generate ATP. So these are the example of the upper limb muscle fibers. And these muscle fibers, because they can do a heavy job, which means like their muscle fibers are much bigger. These muscle fibers, they are just slow and contract for the all day, which means they are slower. And their fibers are smaller. So something in between, which can be fast, which can last long. So it is like a hybrid, trying to get the best side of both. So that example is the muscles in our leg, lower limb muscles. So these fibers, some of the fibers here, we use oxygen. Some of the fibers we use glycolysis and combine together. That's why we can say fast glycolytic fibers. Fast oxidative fibers. So they will contract quick. They will use oxygen. They will use glycogen. They will use both. They are all combined. So these are the muscle fibers in our lower limb. So the best example is you can train a person to sprint like Usain Bolt. His muscles are his lower limb muscles in the legs. They are fast glycolytic fibers. And can he run long? I'm not sure, but let's say he might be able to run for a good distance, because if we train Usain Bolt with another type, like oxidative fibers, then he will be able to run marathon. So that is the way, we use the muscles in our lower limb to make a person who should be a sprinter or who should be running for marathon. So that is really interesting. And of course, if we do the cross section, because loss of myoglobins, therefore the color is dark and therefore it is slow oxidative. Fast glycolytic fibers, there is no myoglobin. They are pretty pale and white. In between, like fast oxidative, they are fast as well as they use oxygen, fast oxidative. So they are somewhere in between, brown, dark brown and white. So that is all about this. All right, so I hope it is not that difficult, because we are coming back as a second time. And this is a diagram of motor unit. So if we look at that, this is our spinal cord. This is anterior, and here will be posterior of the spinal cord. This is the right side. This is the left side. all the nerve fibers from the brain ran along the spinal cord and then come off at the different level to supply the different nerve supply. So all the motor mean movement, all the motor fibers, movement fibers came from the front, come out here like that to the muscle, and all the sensation fiber will go from the back into the spinal cord. So motor fibers will come out from the anterior horn of the spinal cord. Look like this is like a little horn. So this is anterior horn, and that is the posterior horn, right posterior horn, left posterior horn, right anterior horn, left anterior horn. So from the anterior horn, motor fiber will come out and go to the muscle fiber and supply it. Another motor fiber will come out from the anterior horn, go along the spinal nerve and go and supply it. So if you look at that, we have two fibers. One is color with red, the other one is color with purple. So they are different. The purple will go to its particular fiber, muscle fiber, two fiber, and the red will go to its particular fibers here. A motor unit is a combination of the motor neuron, so only one motor neuron, the purple, with the supply of the muscle fiber it's supply. So these two. So combination of this muscle fiber and this muscle fiber together with the motor neuron, it is called motor unit. So the purple motor unit has got motor neuron axon plus two muscle fibers. The red motor unit has motor neuron axon plus three muscle fibers. So that is the way they supply the muscles. So nerve fibers come out from the anterior horn cell, leave these ventral rami and come out and go and supply the muscle fibers. So these are the nerve going close to the muscle fiber. And when these nerves get close to the muscle in this area, let's zoom into this area and have a look what's going on here. Hey, that is what happened. You know, this nerve will end here close to the muscle fiber, and finally it's branch out again. That is what they call terminal buttons. One terminal button, another terminal button, another terminal button. If we look a little bit more detail in this junction between the nerve ending and the muscle fiber, we have it. So the nerve with after stimulation, it secretes acetylcholine into the space between the nerve ending and the muscle. That is what we call, this space is called intersynaptic cleft. In between, that is a synapse, and this space is called cleft, synaptic cleft. Acetylcholine will come out from the nerve endings, will go to the muscle, and just doing that, it will stimulate calcium from the sarcoplasmic reticulum to come out and ask the muscle to contract. Hey, it's a lot now, so I'm going to stop. I'm going to stop for 15 minutes. Go and grab. Okay, so we were talking about the motor unit. Motor unit is a combination of motor neuron axon, which is coming out from the anterior horn cell, and the muscle fiber it supply. Yeah, not all the fibers, only the muscle fiber this motor neuron supply. So in this bubble, we have one mast cell fiber and another mast cell fiber, which is supplied by one motor neuron. That is one motor neuron unit. And here, motor unit 2, the red color, the motor neuron with the mast cell fiber it's supplied. So 1 fiber, 2 fiber, 3 fibers. That is one motor unit. And if we look at the distal portion of the nerve fibers, that is what we are going to see. The nerve will stop and then it comes out as a terminal buttons. So these are the little buttons like. And if you look closely to this area, this is the end of the terminal button, and this is the mast cell. There is a space, small space in between the nerve ending and the mast cell. That is what we call synaptic cleft. Synapse means like nerve fibers connecting to another structure. So this is the synapse. Synaptic cleft means little open space. When there is a nerve fiber stimulated, then this terminal button will secrete acetylcholine into the cleft. And this acetylcholine will go and stimulate the mast cell, and the calcium from the calcium will come out here, and then that calcium will go and do the contraction and relaxation. So that is the closer detail. This is the terminal button. This is the synaptic cleft. Acetylcholine will come out here, go and attach to the receptor, and will give you the contraction and relaxation. So once there is calcium, and how does a muscle contract? So let's have a look. This is sarcomere. I believe you remember this diagram is pretty annoying because there are too many things going on, but at least we can pull ourselves together and say, hey, in between two Z lines, one Z and the other Z, it is sarcomere. So inside the sarcomere, we have actin and myosin. Actin and myosin alternate together, and actins are attached to the Z line. Myosins are stay in the center. They will go and attach to Z line via a T10, TITIN, T10 protein, which is like a spiral shape. And if we look a little bit more detailed between actin and myosin, this is the actin, which is the thin, small one, the blue color. And this is the thick, big myosin. You can see the little beads coming out from the myosin filament. That is what we call myosin heads. And if we look more carefully here, actin, which is thin and slim, and we can see this little yellow line and beads. Let's go and look at what are they? So this is the myosin head, and this is the actin. Actin has got a space, little bubble space, which is the place for the myosin head to come and attach to actin. That is what we call myosin binding sites. They are usually hidden or covered with a string, which is called tropomyosin. So tropomyosin block the myosin attachment site of the actin. And you can see these little yellow structures here, which are called troponin. So when there is calcium, which is released from the sarcolemma, and the calcium will come and attach to the troponin. A calcium attachment to the troponin will make the tropomyosin conformation changes. So change in the shape of the tropomyosin. Look at the tropomyosin here. It is really curved and windy, curved and windy. But just because calcium came and attached to the troponin, tropomyosin has shape change, what we call conformation changes. Because from the curved position, when it becomes straight position, then all these purple places for the myosin binding site on the actin, they all expose. Then with this myosin heads, they are just waiting for the time they will go and attach to this area. That is the way, you know. And when there is no more ATP, there will be no more calcium. This tropomyosin will go back to its original shape. No more place for the myosin to go and attach. The muscle relax again. So if we look at the, what do you call the sarcomere, look at that. You know, here, T10 proteins are really pulled. That is the state of contraction. And if we look, this is the state of relaxation. T10 proteins are really relaxed and long. And in a state of contraction, these T10 proteins become really short. So they are like a spring coils. They will get stretched and relax, stretch and relax. That is the way a muscle contract. Yeah, so this is a state of relaxation where T10 proteins are long. Look at the space in between two Z line. So Z line from here to Z here, it is a very wide space. Now, because of the actin and myosin rubbing on each other, this T10 protein will contract and it will happen this shape. The space between two Z, they become shorter, relax, longer, contract, shorter. That is the way a muscle contract. So that is why, you know, for us, this anatomy, like sarcomere, which is the basic unit. Sarcomere is a basic unit of the skeletal muscle, is important. So in between 2Z is called sarcomere. We will have myosin, thick, big, fat myosin, and thin, little, slim actin. They will be alternating each other. Actin will go attached to Z. Myosin will not attach to the Z. And T10 protein will go attached to Z and the myosin. It is the T10 protein length change during contraction and relaxation. It is not the length of the actin and myosin. So if we look at that, relaxation, the length of the actin and myosin the same, and contraction, the length of the actin and myosin the same. It is the length of the T10 protein which change. So that is a little bit too much, you might feel it, but you know, that is the basic of muscle contraction. As an anatomy student, we need to have some working basic knowledge about that. I mean, you can forget about that after this class. But if someone talking about this, at least you understand what they are talking about. And this is the, what do you call that? The terminus system, T-tubules, sarcoplasmic reticulum. These are the places where the calcium will come out. And look at the design it is made. You know, it just go all along the multiple sarcomeres. So when there is a stimulation, the calcium will be released from these sarcoplasmic reticulum and terminus system, and this calcium will go everywhere, and calcium will bind to the troponin. Calcium will bind to the troponin. calcium binding to the troponin, we make conformation changes. We make conformation changes on the tropomyosin. And that way, this conformational changes will give the myosin binding site on the actin open, and myosin head will come and attach to that. That is the way the muscles contract and relax. So of course, you know, this actin, myosin, titin protein, A line, Z line, M line is too much. Yes, it's too much. That's why they know that, you know, these examiners know that we cannot remember these things all the time. That's why these questions come back again and again, again and again. You are undergrad, they will ask you this question. Postgraduate, they will ask you the same question. The master or fellowship exam, they will ask you the same question. Board certification exam, they will ask you the same question because they know that you can remember. So they make sure you try to remind yourself. And therefore, you know, every exam like these, for anatomy, these pop out off and on. So as I say, you know, Z is the end. So this is Z here, one Z, the other Z. So the sarcomere is in between two Z lines. Z is the end. A for all mean both actin and myosin. Area is A, here A band, actin and myosin here. Only the thin actin, where the only thin actin is, that is thin and slim. Actin is thin and slim, and therefore it is I band. If we split I into two split, then we will get the H. So H band is made of myosin, only myosin. And yes, both actin and myosin will be A band. M is in the middle. Therefore, this is the M line. So again, like, you know, this is repetition, and therefore it is no longer difficult, I hope. And this is the hierarchy. Like sarcomere. Sarcomere is the basic structural unit of the skeletal muscle, isn't it? What we need to know. So I'm going to take you to the very, very early slides. That is what we talk about, isn't it? This is a little train. So one coach is equivalent to one sarcomere. Another coach is equivalent to another sarcomere. And sarcomere, 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 sarcomere. All the sarcomeres arranged in linear fashion. So combination of all these sarcomeres, we will get the myofibril. So inside the sarcomere, as we saw, like we will have myofilaments, which are actin, myosin, and titin proteins. Sarcomeres in linear arrangement is called myofibrils. If we combine multiple myofibrils together, we will have muscle fiber. So muscle fibers, we just wrap with the sarcolemma and the endoplasmic reticulum. That will be a muscle cell. So that is equivalent to a cell. Sarcolemma means sarcoplasm, the same. Cytoplasm, the same, you know, cell membrane. And now we have used the term endomysium, yeah. So now we got sarcomeres, multiple sarcomeres in longitudinal arrangement. It is called myofibril. If we combine all the myofibrils, a collection of myofibrils covered with the sarcolemma, and the endomysium, we will have muscle fiber. So this is the muscle fiber, the nerve axon we come attached, that is called motor unit. If we combine all the muscle fibers and wrap around with the connective tissue sheet, which is called perimysium, we will have a fascicle. Multiple fascicles wrap around with the epimysium, outermost mysium, epimysium, we have the muscle as an organ like our bicep muscle. Yes, so latissimus dorsi muscle, big thick muscle, latissimus, big dorsi in the back, big muscle in the back, trapezius, these are they are oxidative muscle, slow oxidative muscles. So these are the slow oxidative muscles. They will be contracting and making you not to fall forward. They will be contracting from your back to make you straight for that whole day long. As long as you are sitting or standing upright, they will keep you upright. Of course, they will get tired at the end of the day, but they can do the job. They are slow oxidative muscle fibers. That's why their muscle fiber has lots of myoglobin, which are the pigments to extract oxygen from the blood capillaries and use those oxygen with the mitochondria, with the help of mitochondria to generate energy. Right. So I hope it is a little bit easier. Yeah, I know it's a lot, but that's the way, we split into 2 lectures and then now we revise. I hope it will make it a little bit easier.
I have a question.
Yep.
Will we be learning the origins and insertions of these muscles?
Original insertion, or let's say important muscles, like our bicep muscles or big quadricep muscles, we will. But small little muscles, like muscles in our hand, we will not. Because it is becoming like too detailed, gradually more and more detailed. So I'm just going to like gradually, slowly taking you there. So big, large bicep muscle, I think we should know, because we all know bicep muscle. Pectoralis major, the big muscle on our chest, we all should know, like quadricep muscle, like in our thigh, big muscle in our thigh, we all should know, but not those muscles in the leg. I hope that's okay. Has anyone got any question? Don't forget sarcopenia. Sarcopenia, it is an age-related changes. As we all know, all the muscle fibers from bugs, there is no mitosis. There is no division of the muscle. So when we were a little baby, we have certain amount of muscles. These muscle bundles on itself were gradually bigger and bigger and bigger. They will not multiply. So if a baby has got 100 muscle fibers, and when we become adult, we still have the 100 muscle fibers. We do not have 200 muscle fibers just because our size is twice the size of the little babies. Muscle fibers do not go mitosis. The number doesn't change, but they will increase in size. They will increase in power. And once we get gradually older and older, we are going to lose these sarcolemma, like all the muscle fiber. Sarcolemma is in myofibrils. We are going to lose muscle. That's the way a human being is designed. So that's why older people, when we get old, we are losing our muscle mass, and therefore we lost weight loss, age-related weight loss. That is physiological. And because we are losing the myofibrils, sarcolemma, sarcomeres, we are losing sarcomeres, in other words, myofibrils, in other words, the muscle bulk, we gradually become weaker and weaker. The older we get, we get weak. And then, therefore, old people like 80, 85, they are not very steady at all. Because it is not just the arthritis giving them pain and making them slow. It is the muscle which is also getting weak because they are losing sarcomere. That is what we call sarcopenia. Penia means gradually less and less, sarcomere. So that is the nature. We can fight, and we can make sure all the remaining muscle fibers are strong and competent by doing exercises. So the remaining sarcomere, remaining myofibrils, remaining muscle fibers, remaining muscle fascicles, remaining muscle mass has the same strength or near equal strength to control ourselves. But whatever we say, we are going to lose the muscle mass. That is what we call sarcopenia. Exercise can help with the strength of the muscle, but we will lose the muscle fibers. We cannot generate it, no mitosis in the muscle fiber. And therefore, if somebody has a cut in the muscle, they do not regenerate. It is not like bone, because in our bone lecture, we said, we do not, the bone will regenerate as bone.